Hello, everyone. Welcome to the fifth annual virtual conference brought to you by Eating Disorder Hope, Eating Disorders and Trauma. My name is Kirsten Miller-Doberman, and I'm going to be your moderator for the next couple of hours of presentations. We are so glad that you're joining us today and really look forward to learning with you, growing with you, and helping us do what we all do better, treating clients in the field of eating disorders, and very much look forward to and thank you for being here. Before I introduce our first presenter, who is Brooke Mathewes, and she's there on the other side of the screen, I'd first like to tell you a little bit more about Eating Disorder Hope. So EDH was founded in January of 2005, and its mission is to offer hope, information, and resources to individual eating disorder sufferers, their family members, and treatment providers. And through EDH's articles, blogs, online conferences like this one, online support groups, videos, treatment listings, EDH promotes ending eating disorder behavior, embracing life, and pursuing recovery. And of course, if you want to learn more about EDH and all of the good things that they have to offer, of course, you can visit their website, which is eatingdisorderhope.com, or you can follow them across any of the social media networks, Facebook, Twitter, Instagram, and LinkedIn, to read more articles and share those resources with your patients, with family, friends, and colleagues. Also, before we dive in, I would like to thank our very generous sponsors and partners without whom today's virtual conference wouldn't be possible. So I'd like to extend a big thank you to Timberline Knolls Residential Treatment Center, Sierra Tucson, McCallum Place, Montecatini, The Refuge, Carolina House, Laureate Eating Disorders Program, and the University of California, San Diego Eating Disorders Center. And we'd also like to thank Meta, Project HEAL, NEDA, the Eating Disorders Coalition, Rock Recovery, and Addiction Hope for their partnership and support as well. So two other housekeeping notes before we begin. One is that all the presentations in today's conference are CE presentations. And if you are attending, you are eligible for a continuing education credit. But very important details: in order to receive your CE, you will need to be present for the entire presentation, and you have to be logged in via the email that you registered for the conference. So those are two very important things that we have to use to validate that you are here. After each presentation, then I will put a link to a survey in the chat to all attendees. You will have to complete this survey and submit it in order to receive your CE credential. You will receive that via email before December 31st, 2020 of this year. So CEs, make sure you're logged in with your email that you registered for, make sure you're here for the whole time, and submit that survey, and you'll get your CE credential. Last little bit of housekeeping. We will, at the end of Brooke's presentation, about the last 10 minutes, be answering your questions. So if you have questions throughout the presentation, you can type them in the Q&A, you can type them in the chat. I will be moderating, and I will present those questions to Brooke at the end of her presentation. So that's all I've got on my end. Now I'm going to introduce Brooke and hand the screen over to her. So Brooke Mathewes is a faculty member of the Clinical Development Institute at Timberline Knolls. She's worked for a number of years as a therapist, consultant, and supervisor. She started her career in Canada in a variety of different settings, from community agencies to hospitals to the private sector. All of her work has focused on helping those with mental health, substance abuse, and trauma issues, as well as psychosocial oncology. Brooke started at Timberline Knolls as a primary and family therapist. Brooke received a Bachelor of Arts degree in communication with a minor in psychology and a postdoc baccalaureate diploma in counseling and human, there's a word here missing from your bio, but development.
Development.
Thank you. Human development from Simon Fraser University in British Columbia, Canada. She went on to earn a Master's of Education in Counseling Psychology from the University of Victoria in British Columbia. She is also a certified trainer in feedback-informed treatment. So without any further ado, Brooke, the screen is yours, and I look forward to your presentation.
Okay, wonderful. Thank you so much for having me. And this is an area that I'm very passionate about. So I'm always excited when I get to speak with you all. I have a lot of content today, you guys, so I'm gonna go through it. Normally we would be doing interaction as we go, but I think best we'll just keep your questions at hand, and we'll try to tap into them as much as we can toward the end. And today we're going to be talking about the challenge of working with co-occurring disorders as it relates to eating disorders and trauma. So as Kirsten said, I'm originally from Canada. She went over sort of all of my credentials, but a big part of why I came from Canada was to work in an environment where I would be able to interact with a variety of co-occurring symptoms and treat them holistically. In Canada, sometimes we don't always do that. And actually there was nowhere like some of the facilities that are in the States to do that. So I started as an individual and family therapist, and then I moved up through into administration before moving back into private practice and working as a supervisor and trainer. So just a couple of statistics about the impact of eating disorders. So more than 30 million people in the United States will suffer from an eating disorder at one point in their life. The National Institute of Mental Health states that eating disorders have a 10% mortality rate. So it's one of the highest rates of mortality in the mental health area. And it's been estimated that one person dies from an eating disorder every hour in the US. And I've heard recently that statistic might be that it's even less so, so it's like one every 45 minutes. And today what we're going to be doing is we're going to be talking through the connection between eating disorders, trauma, and co-occurring disorders through the discussion of a real life case study. And this is going to be mostly focused at a residential level of care, but I'm happy to speak to how you would work with these types of issues at an outpatient level of care as well. But we'll be doing it through all of the identifying information for this client has been altered or changed. But we're going to be walking through sort of her treatment history, what happened in treatment, and what happened after. But first, quickly, we're going to discuss some statistics around the connection between eating disorders, trauma, and co-occurring disorders. So this first slide is from NEDA. And in a survey of people who responded with eating disorders, these are the percentages that most of them exhibited with other co-occurring disorders. So those with anorexia had more than one co-occurring disorder. 56% of them had more than one. With binge eating disorder, 79% of them had one or more co-occurring disorder. With bulimia, 95%. And interestingly, in that bulimia category, 64% of those actually identified having 3 or more co-occurring disorders. And this was in a study of women with eating disorders. So you can see that there's a very high correlation through all of these different diagnoses with having the presence of other symptoms. In terms of eating disorders and substance abuse, according to the National Center on Addiction and Substance Use, 50% of individuals with eating disorders abused alcohol or drugs. And that translates into being 5 times higher than the general population. 35% of individuals who abused or were dependent on alcohol or drugs have also had an eating disorder. And that translates into being 11 times higher than the general population. So again, there's a strong correlation between substance use and eating disorders. And we'll jump into a little bit of a breakdown of the specifics. So again, if we're looking at the specific, different components, anorexia, 27% of those with anorexia have identified as struggling with substance abuse, 23% with binge eating, and 37% with bulimia. So again, when you're thinking about working with individuals who are struggling with eating disorders, these are the types of areas that you want to be just mindful of, knowing that there's a close correlation. So to be assessing and watching out for them. Oh, my trauma slide. Hang on. Okay, here we go. All right, so eating disorders and trauma. There's a 50% co-occurrence with those struggling with eating disorders and those identifying as having traumatic experiences. If we break that down into the specifics, so 23% of those with anorexia and 25% of those with bulimia were actually diagnosed with PTSD. There's a correlation between more experiences of trauma and the complexity of the trauma, and then greater psychiatric comorbidity, which makes sense. And then in the US National Comorbidity Study, nearly all men and women with an eating disorder diagnosis reported a history of at least one traumatic experience. So again, we're not often seeing these things in separation. It doesn't mean that somebody couldn't have an eating disorder or could have an eating disorder without having trauma. But again, we want to be understanding that these things are so closely connected that it's important to be assessing for them. And so again, trauma, substance use, and eating disorders are all very closely connected and interconnected. Same with trauma and substance use. And this is a little bit outside of the eating disorders, but if you can understand the triangle, then it makes a little bit more sense. So those who struggle with substance use, 50 to 66% of them have a co-occurrence with traumatic issues. And I think this is interesting because if you can understand how some of the addictive behaviors develop with trauma, you can understand some of the needs that get met through it. So a big one is to control mood and emotions. So oftentimes when you've had traumatic experiences, emotion regulation becomes an issue. Some substances temporarily will help with that. Over the course of time, we know that that changes, but in the moment, it can be an effective tool. There's often a reports for those that have had traumatic experiences of all different kinds, that there is an isolation with that, or a deep sort of sense of aloneness. And they're constantly looking to fill the void. And again, substances will temporarily either help numb that feeling out or will actually fill the void temporarily. For many of those who have suffered trauma, the body holds on to that trauma memory in a different way, and we'll talk about that in a little bit. But it can help sort of, again, numb those sensations or reduce the experience of pain. And another thing that often people will talk about is how human-to-human interaction has led them to develop mistrust, and to a lot of these traumatic experiences have involved other people. And substances will not do that. They can rely on it, again, for a short period of time to do exactly what they need. And they describe it as being a friend, but really it's a replacement for the human support that they have not been getting. So again, these are just sort of general statistics. Much of this may be reviewed to you, but so you can sort of understand the correlation between all of these things as we jump into the case with Anna. So we're going to start with Anna's clinical history and background. As I said, all of her identifying information has been altered. So the first thing is, why would we be talking about a case study? First of all, it provides a real life example of how co-occurring symptomatology presents itself. There's often a lot of different moving pieces all at the same time, and sometimes it's hard to imagine that it's all going on at the same time, but this is a real life example, so you can sort of see the flow of how it plays out. The other thing is when we start talking about co-occurring disorders and trauma and eating disorders, it's very easy to get focused on siloing the specific sets of symptoms because it can be overwhelming. This is a reminder that this is what's happening to one person all at the same time. And so when we speak about it in a real life example, it helps sort of bring that to light a little bit. And then it helps the compartmentalizing conversation. So we're going to go through her clinical history. So Anna Doe, she's 24, she's female from the Boston area. She's been in what she reports as a serious relationship for 3 years, but is not married. She's attending college and is in her second year of pharmacy school. Her trauma history is such that she has disclosed a history of childhood sexual abuse. It occurred between the ages of 7 to 9 by a family friend. She also had 2 sexual assaults that took place when she started drinking more problematically between the ages of 18 and 23. Nobody knows about these. So these are not situations. The childhood abuse and the incidences when she was drinking have never been discussed or processed with any of the people that are in her life, including her relationship. From a mood perspective, she started to experience symptoms that were connected to anxiety and depression around age 14. This also coincided with an eating disorder diagnosis. She typically was dealing with emotion dysregulation. She started to experience impulsivity, and she really struggled to contain her emotions even when she was trying. At around age 14, again, she started to self-harm and was cutting. And she's had that sort of behavior on and off, with the longest period of abstinence being about 1 year. And then in terms of suicidal ideation, she had intermittent thoughts, but that were usually connected specifically to any loss of attachment. From a substance use perspective, she started drinking at age 14. For her, she says she started drinking problematically at age 18. And this is when she started binge drinking. Along with that, she started to engage in a variety of other risky behaviors: promiscuity, driving under the influence, and frequently drinking to blackout. And then as a result of that, she had 1 DUI and was mandated to a substance abuse outpatient program for treatment. And then around age 20, she started to get access to benzodiazepines and started using those with alcohol. And that was sort of her adult use. When it comes to her eating disorder history, as we said before, she had her first diagnosis at age 14. She was in a pattern of restricting and purging. The restricting eventually stopped, and she remained with sort of a binge purge cycle, and she would binge anywhere from 2 to 4 times a day. She had intense body dysmorphia, very strong fear of gaining weight, and saw herself as obese, even though her BMI was 19. And there was some connection to family history with eating disorders, anorexia with a sibling, and orthorexia, so sort of the obsession with clean eating, from the father, who had been obese as an adolescent. In terms of treatment, she had 1 residential stay for bulimia when she was 14, so that was sort of the first stint, and she completed treatment. When she had the DUI, she was mandated to substance use treatment, PHP, IOP level. She left, did not complete that program due to a school conflict. And then she had outpatient therapy ongoing for about 2.5 years. So this is exactly sort of what we often see. So somebody that has had multiple episodes of treatment, all for different things, all at different times, but not ever having treatment to address all of it at the same time. So now we're going to move into sort of what she looked like when she came to us and we started working with her. So this is Anna's transition into residential treatment. So she came directly from inpatient. She had had her first suicide attempt via fentanyl overdose, and she had stolen that fentanyl from her school. She was pretty open and talkative about her experience, what had brought her there. And she was very clear that she was willing to be here, but that basically she had received an ultimatum from her boyfriend, and probably wouldn't be in treatment had she not had that incentive. She also was pretty honest about her current purging behaviors and her substance use. And for her, substance was sort of the primary and dominant thing that she could identify as being something that was causing problems in her day-to-day life. So that's where we started. She identified that as being the biggest issue. That's where we started treatment. So in terms of her substance use, she had basically been 2 weeks free from alcohol and benzos when she came into our care, because she had been hospitalized from the suicide attempt. So she already had a little bit of time without substances in her system. As a result of that, she was having intense cravings because she had been having daily use up until that point. And she was getting sort of fixated on this idea of like, I can't manage this, I can't do it, I can't control this, and I can't imagine my life without drinking. So, you know, often people will say, where do you start? And because the client was sort of motivated to start by saying, okay, I can understand that this is not good for me, but I can't imagine my life without it, we started just sort of basic education on understanding what might be going on for her, and to help her realize that the things that felt automatic, out of her control, even out of her awareness, that with some practice, we could start bringing those things into her awareness and then developing strategies for how she could get off of this cycle at each different level. This is something that often people forget to do because, probably the majority of you have seen this type of, graph or diagram before. Tying the skills that we're teaching them so that they can understand exactly how and when they're going to be able to use them is something that often gets missed, and helping them build skills at each of these different stages, understanding that the sooner you get off the cycle, the better off you're going to be, or the easier it's going to be to manage it. So this is a strategy that I use a lot. And again, focusing on helping her understand what feels totally out of her control is actually, there's aspects to it that she has a lot of power and influence over. And then at the same time, starting to develop internal resources and skills. So, of course, we know that there's purging happening at the same time, but we started with the place that she was more comfortable with, acknowledging that there's these other things that we have to address as well. Some of the other interventions that we used here, motivational interviewing, because there was some ambivalence about her capacity to let this go. Very specific, concrete, and detailed relapse prevention for the level of care that she was currently in, and also a little bit of harm reduction. So she was saying, I can't imagine not drinking again. So we started the conversation around how do you get to a place where you can acknowledge that you're just not going to drink when you step down to PHP, right? So rather than saying you can never have another drink again, you have to be abstinent forever, helping her stay in a range that felt a little more manageable. So for her, much of her substance use was actually ended up being connected to her purging behaviors. So not only did the substances allow her to function more within a social circle, so it reduced her stress and anxiety, but it also allowed her to purge a little bit more easily. So there was a very strong link between these two behaviors for her. And as a result, given the fact that she'd already been substance free for a couple of weeks, we started to see her anxiety increase as she didn't have access to those substances. And so as a result, her purging behavior increased. This is something that we know happens with people who are struggling with co-occurring disorders, but it doesn't always feel like it makes sense to the client. So it becomes really important to start creating a space where you're normalizing this. So for her, she feels like she's getting worse. And for us, we're just saying, hey, we've ripped away one coping strategy. It makes sense that the other one is going to get a little bit more activated. This is where sort of the foundational skills about grounding and sort of distress tolerance become really important. So how do we just get you to tolerate being able to breathe, or being able to sit with your feet on the ground, just to be able to sit in a room without pacing, things like that. So working just from the very foundational level. And then when you're at a residential level of care, there's some environmental controls that can be put in place that will then help to build those internal resources. So in her case, it might be bathroom monitoring, or locking out of the bathroom after a meal, or smaller meal support groups, teaching about healthy distraction and how to tap into your senses to be grounded. The other thing is when you're working with so many different complex sets of symptoms, you want to have interdisciplinary support. And I know this can be a challenge at an outpatient level, but if you are going to take on a client where you know that they've got a variety of these things happening, the goal is to then start pulling in other resources so you aren't the sole set of eyes, because it can be very overwhelming to have all these different things popping up at the same time. So in Anna's case, I was her individual and family therapist. Then she had an eating disorder specialist. She had a dietitian, and then there was also medical support. And so we would be working on therapeutically all of the different things that were going on. And then the ED specialist would come in and maybe work on specific anxiety management for meal support, or trigger foods or fear foods and things like that. It was at this point we also started to work on building in expressive therapies as well as somatic therapies. So again, when you're working with eating disorders, this can be really tricky, and it becomes really important to know exactly your particular client, because they may have medical issues that prevent movement. In this case, it was restorative yoga. So it was more just laying in one place and helping her getting connected into her body in a way that felt manageable, because being in her body at all without sort of these other external coping strategies was completely overwhelming. So as we did this, we started to reduce the eating disorder behavior. So she's not using substances. She starts purging more. We start focusing on reducing the purging. And as we start to contain that behavior, then we start to see a new worry emerge, and she starts having increased self-harm urges. The good news here is at this point, with the foundational skills that she started out with, she was able to effectively manage those urges without acting out. So again, distress tolerance, healthy distraction, and using supports around her kind of helped her get over that hump. So from our perspective, this is the first time that her team and I all acknowledge, wow, there's some progress happening here. You know, she can see that she's tolerating things a little bit differently. She's purging less and less over time. She was managing urges and didn't act out on them. And she was starting to see some benefits and a reduction in her cravings to use substances. So we think we're kind of on the upswing here. And then all of a sudden, we get reports from her team that she has lost weight. And the one thing with her is she didn't always bring information forward, but if you asked her a direct question, she rarely didn't tell you the truth. So she disclosed that yes, she had been sort of stashing away food and had found a way around meal support, and she was eating less. And she acknowledged that she had heightened anxiety and emotional dysregulation, and that had triggered her to restrict because she just couldn't handle what was happening internally. So this led us to have some conversations about her underlying trauma beliefs, and this piece is really important. The first thing she said to me when we asked her that question is, she said, "Are you going to fire me as your therapist? Are you going to fire me now because I've done this and I'm not getting better?" And you know, that I thought was a really interesting question because she just felt like the team was going to give up on her. And that's when we started to kind of look at how is she seeing the world and how are the experiences that she's had impacted the lens that she's seeing all of us through. So the thing to understand with trauma is that you're rarely, or you're not often going to hear someone say, "I believe I'm fundamentally unlovable," or "deep down, I know I'm broken." They won't say those exact sets of words. So you have to be listening for the themes, because for most people who have experienced trauma, they are going to have some or a variety of these beliefs, and these beliefs are going to shape how they're interacting in their treatment. So for her, she had a fundamental belief that she was unhelpable and that she was unlovable, and that no matter what she did, these things were going to come back and get her, and there was nothing to be done. And that really sort of started to shift some of our conversation. So if you can imagine, if someone believes that they're unhelpable and unlovable, they are going to have a very hard time engaging in what we're asking them to do. Because when they come into treatment, we strip away all the coping strategies that have helped them survive up to this point in their life. Then we say to them, "You don't know me, but I need you to trust me. You're going to be incredibly uncomfortable. The skills I'm going to give you are going to take some time for you to implement, and you may not actually get relief right away. You're just going to have to trust that it's going to come." That's a big ask for somebody that has a belief that they can't trust the world, or that no matter what they do, nothing's going to make a difference because they're so flawed. And so oftentimes as therapy professionals, we can start to see some of the behaviors that show up as a result of these beliefs as being resistant, or they're not ready. When in actual fact, it's about unpacking, how did that lens get created for them? How did their history and trauma potentially set them up to be interacting that way with us? And then we can find ways to start unpacking that story in a more effective way. So then she had a breaking point in therapy. Her boyfriend called about 3.5 weeks in to treatment and said the relationship is over. So some people often react really strongly to this and say, how could he do that? You know, from a treatment perspective, we look at that and say, if he was going to do it, the best time was for her to be doing it when she was in 24-hour care. So we saw a marked shift in her presentation at this point. Her anxiety skyrocketed, her bright affect diminished. She started to have obsessive thinking and rumination. And she started to have increased mood dysregulation. She was sort of behaving a little more erratically, and her self-harm urges went up. So if you remember back to her history, her depression and reactivity was often tied to sort of the disruption of social relationships. And she would sort of get impulsive and agitated, and also very depressed about the situation. So in her case, it really seemed here like this was the final loss of attachment. She really was like, it was like having the rug pulled out from underneath her. And we needed to work to figure out how to help her start to create some safety and some meaning within herself. We start to see attachment issues and codependence arise with other residents. And we also start to see activation of her trauma symptoms for the first time. Start to have nightmares, flashbacks, periods of what we would describe as potential dissociation. So kind of losing time, especially in the evening and when she was on her own. And most of the nightmares, not to your surprise, would be about loss of attachment or being separated from people. This is the first time that she ever starts to experience flashbacks. And interestingly, they were flashbacks to the assaults from when she had been drinking, things that she'd not ever remembered before. So this was obviously very distressing for her because, again, now she's seeing a level of reactivity that's very unfamiliar and then new sets of symptoms. So she reaches her breaking point, and this is the first time that we really see her eating disorder and her mood join forces. And she carved quite a large portion of her arm with the word fat. And this was sort of her first incidence of really intense self-harm. And this started a period of days where she was just frenzied in accessing anything she could to self-harm with. The plug ends of a lamp or pen caps or anything plastic. The most creative thing she did is she actually was able to unscrew the hardware of one of her doors and use the metal hardware. I think our campus went staple free after her. She just, the intensity with what she was experiencing internally just was so overwhelming to her. And again, I could go in and speak with her. We would do a walkthrough of the room. She'd hand over all of her stuff. We'd make a plan for how she was going to get through the rest of the day. And then she'd come back the next day and say, I couldn't do it. I tried, but I couldn't do it. And, so in those moments as the treatment team, you can feel like no matter what you're doing, nothing is helping. But the thing to remember is this, as painful and difficult as it is, it's not a huge surprise based on what's happened. So we as the treatment folks have to remember that and continue to hold the hope because the client won't necessarily be able to. So we have to feel like we can do that to hold the space for them. And sometimes when this starts going on internally, we as clinicians can start to feel frustrated as well. So we had to sort of shift gears at this point and really focus on how to start reestablishing a sense of safety. So we kept working with the DBT skills, distress tolerance, emotion regulation, how to start applying some of those skills within her relationships with the people around her. Grounding again through tapping into her senses, breathing, sort of simple mindful practices, but things that were short, concrete, and easily able to build into her day-to-day life. And then again, continuing with the expressive and the somatic therapies. And this is, again, really important to know each client because with someone who has had trauma like she has had, and certainly trauma that has been unprocessed, it becomes really important to not overwhelm their system and to connect to what it feels like to be in their body in a way that creates relaxation as opposed to fear or pain or stress. The one really interesting thing that happened is as she lost that relationship, we started to be able to talk about her own sense of personal values. So if she wasn't going to be in a relationship and what did she want after treatment? What were the things that she used to dream about? What were her hopes? And of course, many of you know, if you've had these conversations initially, you get a lot of I don't knows, but working to start to change the dialogue from how do I not drink? How do I not cut? To if those things were gone, what would I want to be doing? What fills my spirit? What gives me a sense of meaning and purpose? And we started to have those dialogues. We started to see her self-harm behavior reduce and eventually eliminate as we started to spend more time talking about her identity and her hopes and dreams for the future. The other big part of this was to really help educate the client about how trauma might be impacting how she's seeing things, what's happening, and the symptoms that she was having. So I love this image from Bessel van der Kolk, which just basically highlights that the way traumatic memory is stored in the brain and body is different than everyday memory. And for those that have PTSD and are having these trauma symptoms, there can be moments where their body actually continues to behave in a way that's the same as when it occurred with the trauma experience. So it kind of makes it feel like it could be happening right now. And again, that is really important for treatment providers to understand, because there can be some odd expressions of that, you know. So for you or I, the scent of something or the sound of jingling keys is not going to cause a big reaction, but for somebody that has had a traumatic experience, that sound alone, just like here in the diagram, that sensation triggers the memory, that then triggers the re-experiencing of the scenario, and usually then triggers the stress response, which puts the person into fight, flight or freeze, which at that point we know prefrontal cortex has shut down, emotion brain and, you know, sort of evolution takes over. And then at that point, it's just about getting grounded again before being able to think things through. So really helping her understand these mechanisms so that she can then figure out how to implement different sets of skills at different times. We also then moved into kind of discussing her relationship history and how she had had a series of monogamous relationships that often overlapped. So 3 years with one, overlap between the two, 3 years with another. And she started to see that how her codependency on people had really been only holding her back, and that it was about a way of managing fear as opposed to a way of moving towards something that she actually wanted. Interestingly, she discovered she had no desire to be a pharmacist. She thought it was really boring. And initially, when she had come in, she was going to get kicked out because she had been stealing benzos. That was what prompted her to steal the fentanyl to overdose, because she knew she was going to have sort of some disciplinary action at school. She realized that she had really only been there because she was following her boyfriend there. So now, with him gone and her being removed from the program, what was she going to do next? And this was the first time she started to kind of connect to this idea that she had to make the decision for herself and figure it out for herself. And this was the first step in her starting to really get connected to the internal resources that we had been talking about. So that's a lot. That's what happened. I'm sure there's some questions around how long was she in treatment, those types of things. We'll talk about her recovery path just in a second here, and hopefully those will get answered for you. But just to sort of summarize what we were able to do, she stabilized off substances. We were able to eliminate her purging behavior, and we reduced the restricting behavior. We stabilized her mood. We were able to eliminate self-harm again. We started to reduce the trauma symptoms, and we started to get her prepared for a transition to a lower level of care. So that's really key when you're thinking about treatment here. Whatever level of care you're working with people at, the goal is to get them prepared to step down to the next level of care. So residential, it was to step down to PHP. When you're working at an outpatient level of care, you know, it can be a longer term process. And really, again, making sure you're not the only person with a set of eyes working with her, so that there's breaks in between and she's getting different access to different resources, but there's sort of a team approach overall. The other thing is family work. Now, you know, I didn't talk a lot about that, but we did family work every week, even though she was not willing to let me speak directly with her family. And over time, we started to understand why. So her father, she realized kind of in processing all of this, that her father had struggled with disordered eating. He'd been obese as an adolescent, and he had really sort of taught the family about the identity, the idea that being thin was healthy. And if you were not thin, you were not valuable. And that you just needed to work harder at being thin. And then if you worked hard enough at it, you would achieve it. The family was a great financial resource for her, but in terms of all of the internal work that she was doing, she realized that a lot of the values that she had gotten came from a place that she didn't agree with and couldn't see herself identifying with going forward. So even though I couldn't work directly with the family, we were still focusing an hour a week on what are you going to do when you integrate back into that system? And when you're thinking sort of generally about treating with families, you want to think about also how to educate the family. So, at a residential level of care, there's a family dynamics group that is for the client, and then a family dynamics group for the families. And basically, they cover the same content each week so that it gives some shared language around how a client is making change and what the family can do to support it. It also helps sort of pull away from the idea that the person is the problem, and that really there may be dynamics within a whole family system that need to shift to support health and wellness going forward. So I think I always want to put a plug in for the importance of doing the family work, and that work can still be touched on even when you don't have consent to work directly with family members. So in terms of her recovery path, she spent 3 months in residential before stepping down to PHP. Now that can be a long time, but because she had various sets of symptoms showing up pretty consecutively, we were able to make a case to extend her time pretty regularly. Once she was in PHP, she had about 2.5 weeks, and she relapsed on alcohol. She was stepped back up to residential. Interestingly here, when she was stepped back up, she was moved to a different area, a different lodge, and she started to report psychotic symptoms. She was having auditory hallucinations. So this was interesting because we didn't see that coming, and she hadn't had it before, but she had made close friends with someone who also was displaying psychotic symptoms. So we had some wonderings around if it was more about creating that sort of intense connection. We didn't take any risks though. She was hospitalized. She had med changes. The psychiatrist felt pretty confident that how she was having these symptoms show up made sense. And so then she came back. She stayed at residential for another month, stepped down to PHP. This time she went back to Boston to be closer to her family because she'd had the psychotic symptoms, and that went very poorly. Because the family had not sort of integrated any of the new learnings in, she went back into that environment and then immediately sort of slid backwards and made the decision to come back to Illinois to go to intensive outpatient, where she has remained. Since she's been with us, she's stayed in outpatient therapy. Last reports were that she had a job. I think she was working at Starbucks. She was in a new relationship. And the biggest challenge had been navigating how to interact with her family in a way where she could stay stable. So the interesting thing here is there were many times throughout this process with her where we would not have predicted how things ended up. We felt she may never get better. But in actual fact, part of the reason that we always speak about this case is because even though she didn't move in a linear line toward recovery, it was sort of up and down and back and forth. She was always making progress, and at the end of the day has been able to get into quite a functional state where she is sustaining herself. So it is possible, even when at times it looks grim. So a couple of bigger picture items here. When you're thinking about the philosophy of treating co-occurring disorders and trauma, there's sort of a hierarchy of things to consider. So safety first always. So that means that sometimes substance use interventions and eating disorder interventions are going to be at the forefront before moving into the trauma work. Now, you'll notice that we didn't do a lot of in-depth processing of her trauma. I would argue everything that we did was a form of trauma work, but really what we were talking about was getting her stabilized as she stepped down, with the intent that when she stepped back to outpatient, it was at that point that she would probably start processing some of the more delicate intricacies of her trauma. It would not have been appropriate for us to do that when she was active in all of those other behaviors. So that speaks to the next point of really think about the goals of the level of care. What's reasonable with the amount of time we have, and building those resources and foundational trauma skills from the bottom up before delving in. And sometimes clients need to be taught that, because they will often come into residential and say, I just want to process my trauma, have it done, and then get back to my normal life. That often doesn't play out that way. All of this is required. All of those resources and distress tolerance and emotion regulation is needed to be able to do that other work. And that other work may be more beneficially done with someone that they've got a longer standing long-term relationship with. The other thing that's so important is to remember that you need to make a decision based on what is showing up in the moment with the person in front of you. So having a variety of treatment modalities, but having an evolving presentation and an evolving treatment plan as you're moving along with them. Kind of being rigid about treatment modalities or when these things get introduced doesn't typically go well with this population and this sort of set of symptoms. The trauma-informed approach is really, that's sort of what I was speaking about just a minute ago, of really thinking about how have the experiences that they've had shaped how they're seeing the world. And then as a result of that lens, how do we need to be interacting? And there's some things that are going to potentially trigger moments of trauma, like bathroom monitoring or meal lockout or exercise restriction. All of those things from a trauma perspective can be triggering. So that's where it becomes really important to help them understand, this is why we're doing this. We're doing it temporarily so you can get to this outcome. You know, I understand it's going to be uncomfortable. We'll work with that. And then it's not just about the technique. If there's one thing that I can impose on you, you know, we as treatment providers come with a great sort of arsenal of expertise and experience, but really the most important thing is our capacity to connect with people and to connect in this moment with this person in this scenario. And that has to be adjusted person to person. In order to do that, health providers need to be grounded. They need to be able to focus and actively listen. They need to be able to pay attention to the small changes and remain attuned to those things. The more acute the person or the environment, the harder it is to do that. So this is my shameless plug to say, and certainly in our virtual world, pandemic world right now, we as treatment providers really need to be mindful about where we're at. How are we regulating ourselves? How are we showing up today? What's in the back of my head that's going to get me distracted? Because what we know is that skills in attunement and responsiveness are the key to being able to adjust to treatment plan, to repair ruptures in the therapeutic alliance when they happen, to build trust with those that are not necessarily trusting, and to be able to make those adjustments on the fly. So this is something that I've done some research on, and you know, I think everybody knows the word attunement in the treatment world, but we don't often actually talk about how do you build skills in attunement. So attunement in its most basic form is the capacity to connect in an authentic way and in a correct way, and then to also make adjustments as the relationship is progressing. And so a big part of why I have focused a lot of my clinical work using feedback-informed treatment, which is not a treatment modality, it's just a way of tracking outcomes, is so that I can have a baseline with all of my clients to know day to day, am I helping with them? And if I am, that's great. But more importantly, if I'm not, then what are we going to do? And there was an article that just got published in the Psychotherapy Networker in January where I talk about this, how in my personal life, riding horses actually helped build my skills in attunement with people. And I started to realize that part of the reason that I was able to help the people the way I was because of my capacity to really ground and connect with them and make these small adjustments. So, you know, I'm doing research with a psychologist, Scott Miller, where we had planned to take actually 20 therapists to do a training in Montana this October. COVID has postponed that indefinitely, but we will do it eventually. But that's just my personal experience with realizing the importance of attunement and responsiveness, and that treatment modalities have their place, but at the end of the day, it's about knowing when to implement them, how to implement them, and how to make change over time that really allows us to do well by our clients consistently over time. So I know I threw a ton of information at you guys in a short amount of time. Let's open it up to questions for the last 10 minutes.
Thank you, Brooke, so much. Your work is amazing and so much to learn from you. And we
Thank you.
already had comments, people saying, such a great story. Thank you so much for sharing, and that family work is so vital. So really so many things that you're saying ringing true here.
Great.
Do have a couple questions. One of them is from Margie. She says, did Anna end up with other diagnoses, for example, bipolar disorder, BPD, that were addressed?
Yes. And, we intentionally sort of leave that out because the minute we start talking about borderline personality disorder, often that will it can lead to a whole other topic. So yes, we did send her for psych testing, and she did not come back with bipolar. She did come back with a borderline diagnosis. And that was sort of implemented, processed with her toward the end. But again, not getting too wrapped up in that diagnosis itself, because oftentimes that then shifts our lens around how helpable a person might be, when in actual fact, she sort of beat the odds in many ways.
Awesome, great. Mary asks, and you answered this a little bit, but probably some more details. Mary asks,
Sure.
what kind of transitional work was done for Anna to transition to a lower level of care?
Yeah. So she transitioned to a PHP program that was actually still on site. So it was a PHP program with housing. So our goal was to get, like I said at the very beginning, to get her stabilized enough at how can you manage your impulses in such a way that when you have less restriction and you have a little bit more access, that you can maintain the progress that you made. So that was her first PHP, was sort of with housing. And then when she went back to Boston, it was day treatment where she was staying with her family. And that's when it really didn't go all that well. So again, it was a concrete relapse prevention plan. While she was in residential, she was connected with supportive, like a recovery AA. I think, it was AA primarily. And getting a sponsor and getting the process of starting meetings. So all of that stuff was sort of put into place. And then she started PHP, and there was a trigger that happened in PHP where she had an issue with another resident. They got into a conflict, and that's what led to the relapse. So, we always are trying to bridge and not just give someone a piece of paper and say, have at her. There is a full plan in place as the step down happens at each level.
Cool. We got a lot of people saying that they totally agree about the attunement, especially with horses. And looks like Emery says, definitely want info on future attunement training in Montana. Anything coming up out west? Brooke?
Well, so tentatively we have rescheduled for October of 2021, but I think again, we're last year when I said we're bumping it a year, it felt like it's for sure going to happen. I think there's a lot to be seen because we basically bring a pod of people into a very remote area. It's a huge ranch of 15,000 acres. So we'll have to see what happens with COVID. I think if it doesn't happen this October, it'll happen within the next couple of years. What I can do is, I think I have the link. The best thing to do is to check out the article in the Psychotherapy Networker. And I think I have I don't know if I can put it in the chat. Let's see if I can throw it in the chat here. Oh, I stopped sharing. Let's see.
Yeah, with COVID, it's like everything that was on the plan is no longer on the plan, or the plan changes, right?
Yeah. Okay, there. I just threw the link into the chat box. So that will take you to the link to the Psychotherapy Network article, which has more information. The other thing I will do is I've just thrown my email into the chat box there. You guys are more than welcome to reach out to me if you have more questions or information about it.
Oh, I just, sorry, actually, because Brooke, you sent that link and your email to all the panelists instead of all of the panelists and attendees. So I just put it in there again.
Thank you.
And absolutely. So that's to all attendees. And actually the first link there is the CE form. So sorry, I had that preloaded in the chat already. And then I pressed enter and it came through. Okay. So I am going to send you all again So you have the link there. The bit.ly link is the one to the registration. You've got Brooke's email there. And then I'm going to copy and send again, very important, the CE program evaluation form that you will need to click to submit the survey for your CE credit. So that is there as well. I wanted to get that to you before some of you have to sign off. Let's see if we've got any other questions here. No, we don't have any more questions unless anyone wants to get one in the last couple minutes. Brooke, I did have a question.
Sure.
What other members of the treatment team played a really integral role in Anna's treatment and do in a co-occurring situation?
Yeah, so I think you sort of, as I said, there was myself, the individual and family therapist, then we had the psychiatrist. So psychiatrist was monitoring sort of medication assessment and also working with the clinical team. There was an eating disorder specialist. There was also a substance use specialist, and then all of the group therapists, as well as medication management and dietitian, right? So you don't necessarily pull all of those people in at the same time. So when we were working specifically on addressing her purging behavior that increased, we pulled in the eating disorder specialist to help do a little bit more concrete skill work on managing anxiety after meals and that type of thing. We would address it on a global scale in our therapy. Then that person would come in. The substance use specialist, that was the person that helped build the concrete form relapse prevention strategy for the step down to PHP. And then the whole team would meet at least once a week to do a case conference to really sort of talk about how things were going and who needed to step in where. Because if you have all of it coming in at the same time, that also it's too much, it's overwhelming. So it's sort of pulling people in depending as the treatment is shifting based on how the symptomatology is showing up.
Okay, awesome, wonderful. Super helpful. I just sent the CE link. I guess it looked like, oh, here's a great question from Elizabeth. Have you ever teamed up with an equine Gestalt coach for this work?
So my background is in equine facilitated counseling in Canada. So I have done some work with, not with Gestalt specifically, but with mental health professionals. The work that I'm doing now is actually more in training therapists. So it's an interesting idea to think about bringing in a coach that way. But this is really focused on helping build that skill set for clinicians, because we talk about it, we know how important it is, but if you look at professional development and you look at like training in schools, we don't provide anything that helps build or know that we're building that particular skill set, even though we know how important it is. So that's why we're starting with therapists first, or health practitioners. It doesn't have to just be therapists.
Wonderful. Cool. Thank you so much for doing that work. Amazing work. And thank all of you. Brandy says, thank you for your presentation. So many people saying this was so helpful. So Brooke, thank you for the great work that you're doing and the life-saving work you're doing, and for sharing that with us all. Really incredible story. Thank you.
Thank you so much for having me. It's been wonderful to speak with you all.